Good morning, and welcome to this week's episode of Ask Dr. Murphy. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator with the Havey Institute, and I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you doing this afternoon?
Doing quite well, thank you.
Dr. Robert Murphy is the Executive Director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, infectious disease, and public health questions each week here on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be addressing the latest headlines in U.S. COVID statistics through today, January 11th. We invite you to submit any questions you have down below via Facebook at NU Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. Starting with the updated COVID statistics. The average new hospitalizations per day in the United States is 4,969. In 2023, the same week at the beginning, we saw 6,363. Average COVID deaths per day is 180. In 2023, the same week, we saw 747. The new COVID vaccine uptake for adults is 19.4%, for those 65 plus, 38%, and children steady at 8%. Dr. Murphy, your reactions.
Yeah, so we're in the middle of the seasonal peak for respiratory infections, including COVID. So the numbers are way up compared to what they were just a couple months ago. So we have almost 5,000 hospitalizations per day. Of course, this is still down from a year ago, down by at least 1,300 cases. And the better news is that even though there's 180 patients a day dying from COVID, which is really incredible, that's less than half of what it was a year ago. So the mortality rate has gone down. The hospitalization rate has gone down a little less. We don't know how many cases there are because they're not measured anymore. But we have, one of the reasons why we're having as big an increase as we have is because of the low vaccination rate. 38% in people 65 and over, those are at highest risk. Basically 20% overall in adults and only 8% in children. So it's very low, and that's why the numbers are as high as they are. They'd be much lower if we could improve the vaccination rate. And we're going to talk later in the show today about what's happening with flu. So we'll wait for that.
Yes, and that's actually an excellent transition to get into some of the flu and more specifically over the holidays, as you were just pointing on. We did see a raise, an elevation in those numbers, if not as big as in previous years. But can you break down the kind of flu growth as well?
Well, we're in the middle of the flu season. So 38 states are reporting very high levels this year. The flu season peaks December to February. So, we're basically right in the middle of that. And since October, the numbers are 10 million illnesses, 110,000 hospitalizations, and 6,500 deaths. So it's really high. And this includes even 27 children dying from flu. So the vaccine rate is about twice as high as what it is with COVID. 44% overall for adults, 70% in adults over 65, and children 44.9%. So we're seeing much higher rates of vaccination and a lot of disease. So right now, COVID and flu kind of are competing for the respiratory infections that are going on in the country, and flu is way up.
Yes, flu is way up. And sticking back to that COVID question, we were talking about not very high vaccine uptake, but another thing that is lagged behind that we've talked about a lot is antiviral use when you do have COVID, like Paxlovid and others. Can you break down the statistics? There was a great study of use of Paxlovid around the country. Can you break it down?
This is a real eye-opener. So there's two approved therapies for COVID right now, antiviral therapies. So the one is Paxlovid and one's molnupiravir. So the one that has the most data is the Paxlovid. So let's just focus on that. Probably the results will be very similar if you look at what happens with the other drug. But anyway, this is a drug that has 90% efficacy of keeping you out of the hospital and keeping you alive. It's been shown in multiple studies. So that's COVID and flu, these are life-threatening diseases. Look at what's happened. 90% effective. And the studies have found that as many as 50% of eligible patients getting the medication in Utah, the Northeast, and the Northwest. But looking at people in the Southeast and parts of the lower Midwest, it's close to zero. So there's a huge disparity in different regions of the United States and the uptake of this. And so it even includes high-risk patients, anywhere in the country. A lot of them don't even know they're high risk and should be asking for it. And an analysis was done that said that if people who are at high risk, it's not everybody has to take Paxlovid, all right? It's just, elderly, underlying diseases and so forth. It's about a third of all adults. But if half of the patients who are eligible took it, it would have avoided 135,000 hospitalizations and 48,000 deaths. This is just really amazing. It just, the problem is, realizing you're at risk and then getting your doctor to prescribe it and then getting it paid for. Since it's no longer an emergency, technically, it falls into the realm of whatever your insurance is going to pay for. And that means there could be copays. That means your insurance isn't going to cover it at all, and all sorts of things. Basically, any of the big providers, Medicaid, Medicare, and so forth, the VA system, the big groups out there, they pay because they know they're going to avoid all these hospitalizations and deaths. But everybody had the insurance distribution is so varied that just a lot of people have trouble getting it paid for. And the sooner, like we talked about just on Monday, the sooner you take it, the better you do. So, you don't want to wait 3 days to get an approval of a drug that is potentially life-saving.
Mm-hmm. The baseline of the article was, if you are at high risk and you test positive for COVID, you really should take Paxlovid. It will help you.
Mm-hmm.
And sticking on the big three respiratory viruses for this part of the season, RSV specifically in infants has been getting a lot of news because of the new monoclonal antibody treatment. However, it has been in short supply. Can you break down the RSV burden in the United States and why this drug is so effective?
So respiratory syncytial virus, or RSV for short, is another one of these seasonal respiratory pathogens. And every year in the United States, 2.1 million outpatient visits among children under 5 occur. That's enormous. 58,000 to 80,000 hospitalizations in children under 5. That's enormous. 100 to 300 deaths in children younger than 5. And adults at risk also have increases in hospitalizations and deaths every year. So this monoclonal antibody, so it's not a typical pharmaceutical drug. It's an antibody that's made to fight it. If it's given, it's been studied in groups. In this study that we're referring to now, 8,058 infants who got randomly assigned to receive this antibody, monoclonal antibody, that, or a standard care control group where they just got supportive therapy. And they found that in the treatment group, the hospitalization rate was 11 in the treatment group and 60 in the standard group, the control group, the group that didn't get the treatment. And very significant RSV infection occurred in 5 infants in the study group and 19 in the control group. And it ranged a little bit, effectiveness. This was done in Europe, from the effectiveness of preventing hospitalization and death. It ranged between 75% in Germany and 90% in France. So, I mean, even in different countries with different cultures and everything, it was working pretty well. And in the US, this has become a very popular drug, and they ran out of it. And they're releasing doses in the tens of thousands when they really need millions. You know, that's an unfortunate thing, because here people really want it, because these kids are filling up the pediatric beds in the hospitals and the ICUs, and several of them, relatively small number, but still 1 to 300, you know, can die from this disease. So it's terrible. So, but that's another very effective drug that's used for prevention.
Mhm. And speaking of drugs that are used around the globe, there has been some shocking and startling revelations coming out of new studies specifically looking at antimicrobial resistance in Africa and the effect that this resistance is having on populations. Can you break down those findings for us?
Well, in some low and middle income countries, many in Africa, but in other places too, you know, if you want antibiotics, you just go take it. I mean, you can just go to a store and buy them, and you can take it for as long as you want. And so the inappropriate use and misuse of antibiotics leads to resistance. And this has been going on for years. So what's happened? Basically, there's been bacterial infections that have resulted in deaths. And the last data is from 2019, although it's being reported now. 250,000 deaths were from resistant bacterial infections. So it's just this basically become this breeding ground for drug resistance that can cause death. And it's just very, very sad. And it spills over into the 3rd generation cephalosporins that are used to treat very serious infections, like Klebsiella pneumonia and things like that. And a lot of those drugs are now getting resistant. So it just highlights the drug resistance burden that's going on. It's going on here in the United States, but this was the first big data I've seen from Africa.
Yes, and certainly very unfortunate news. It also highlights the need for research and development, continuing research and development of new antibiotics.
Absolutely.
Now, our final story of the day is based in the United States in Philadelphia, and unfortunately, there has been a small measles outbreak. Can you please let us know how this happened and the status of the outbreak?
Well, measles was supposed to be eradicated, and we almost got there in the United States, but because of primarily travel, people moving around a lot, and the highly contagious nature of measles, it's popping back up again. And this just shows you how we have to be vigilant, because again, measles can kill children. It can kill adults that get it. These 8 cases started in December when an infant was hospitalized in Philadelphia after traveling to a country where the virus was pretty common. In other words, there's no successful vaccine program for everybody and whatever. And 2 days later, the infants typically get sick, kind of nonspecific, and then they get the rash, and then typically they make the diagnosis when they get the rash. So they're infectious during that the earlier phase. And so the the infant then infected the siblings and an unvaccinated parent. They all got infected. There's 4 confirmed cases right there. And before Christmas, one of those children violated a quarantine guideline and attended daycare, who then immediately gave it to another 4 children. In other words, those 4 children were not vaccinated. So all boom, got 8 cases right there. That's how fast it can spread. So this is in Philadelphia, and just to keep in mind that even 1 dose of the measles vaccine is 93% effective for life, basically, and 2 shots is 97%. So typically symptoms appear 7 to 14 days after exposure, and then the rash 3 to 4 days following the first symptom. So if there's any suspicion, one thing you don't want to do is bring the kid around other people. Talk to your medical office doctor or the nurses taking care of everybody there if you suspect that you could be measles, because you don't want to affect the people in the waiting room or the people or the staff. Typically, the staff is all going to be vaccinated, but you really want to avoid as much contact as possible.
Absolutely. And just to reiterate, if you fear that you've been exposed to measles, if you fear that you or a family member may have measles, stay home, call your healthcare provider. They will provide you with every instruction that you need to avoid getting other people sick if you do have it. But on that note, I'd like to thank you, Dr. Murphy, for your time and expertise, not only breaking down the COVID articles and statistics, but all of the public health information. So thank you.
Well, thank you, Katie. And keep in mind, measles is a potentially eradicable disease because we have a very effective vaccine out there, and it's not something you have to take every year. Just take the due doses and you're done, and the whole thing will go away. So, hopefully we can get a global public health effort to eradicate this disease too.
Absolutely. That would be an excellent thing to see. And on that note, thank you all for joining us this week for Ask Dr. Murphy. Again, if you have any questions, please submit them down below or to any of our social medias linked in the description. Thank you and have a great weekend.
Have a great weekend.